everyone. It's a dose of Dr. Drew.
It is indeed. Thank you for being here for an early program, very special program where we're welcoming Dr. Bruce Patterson and Dr. Ram Yogendra. COVIDLonghaulers.com is their effort, their project. Those of you on Clubhouse, I see you there. I'm going to ask you just to sit tight and have a listen to what Dr. Yogendra and Dr. Patterson have to tell us about the update on their long hauler findings. Then I will be taking clinical questions from physicians, hopefully, and then we will, if we have time, open it up to the audience at large. So welcome, gentlemen.
Thank you, Dr. Drew.
Thanks, Dr. Drew.
Ram. Dr. Patterson, I'm going to start with you. You've been in virology and medical research for quite some time. You put this thing together, as you said, in the heat of war, where there was a lot of fog and a lack of clarity about what was going on. COVID long haulers, I think you have one of the largest cohorts now of long hauler patients. What have you learned? What are the takeaways? What are the surprises? And what does the future hold?
Yeah, thank you, Dr. Drew. I think it's been an interesting journey since June of 2020, when we first noticed that patients were being discharged from hospitals alive, feeling better, but by no stretch of the imagination was their immune system normal. And now that we have looked back at some of those samples, we realize that they also had reservoirs of COVID in, white blood cells, and in particular monocytes in their blood. And of course, we published, out to 87 days, the presence of COVID RNA, in individuals. And, we really started on the viral persistence track early on. And where we are right now is we've brought together all the immunologic research with the virologic research and found that, long COVID is really a vasculitis. It's vascular inflammation, in particular, an endotheliitis, which is inflammation of the cells that line the vascular epithelium. And it's really caused by the presence of COVID protein, which we've now confirmed, and we'll be sending in the paper on Monday, that these cells, 12 to even 15 months out from acute COVID infection, are carrying COVID S1 protein. And these cells traffic all over the body, and their role in the immune system is to patrol the vasculature and are attracted to a protein called fractalkine, which is produced by endothelial cells. And we really think that's the source of being a long hauler, and it's the source of the vascular inflammation that we see almost across the board in long haulers.
I got to say, monocytes, of all the cellular components of immunity, monocytes have always been a little mysterious to me. Maybe because back when I trained, we really didn't know what they did. What do we know about monocytes now? And is there anything about what we know about them that confers a theory in your mind as to why they would be the ones hiding the virus or retaining the virus?
It's such a great point, Dr. Drew, because when you and I trained back in the day, we just thought of a monocyte, right? It was one cell.
Yeah.
When in fact there's really three subpopulations. There's classical monocytes, intermediate monocytes, and now our favorite, which is non-classical monocytes. And they all have slightly different functions, and they all express different receptors on their surface, which confer these functions. So for instance, classical monocytes have high levels of the ACE2 receptor. So they would be a natural cell to be infected by COVID, in the acute phase, but we didn't see a lot of that. The intermediate monocytes express high levels of ACE2 receptors and a receptor called CCR5. Which has been a major focus of our research and our studies since COVID began. And then the non-classical monocytes don't express any ACE2 receptor. They do express CCR5, but they also express very high levels of this fractalkine receptor. And these cells are essentially scavengers they either get directly infected by viruses and then present those viral antigens to the immune system, or they scavenge dying cells and acquire, these foreign proteins or, viral proteins and present those proteins to the immune system. And that's exactly what's happening in long COVID, is that there's this continuous exposure to COVID or SARS-CoV antigens and protein that's causing this ongoing immune response. And then those proteins and those cells have a propensity to bind to the vascular lining and cause vascular inflammation. And they can cross the blood-brain barrier. They can cause vascular inflammation in the brain. And indeed, we think that's at the heart of the pathogenesis in long haulers.
Yeah, I have felt that there, and I believe somewhere the platelets are involved in this too, because there's a consumptive platelet process. Yep. So I have a million questions, and based on what we've said so far, and Dr. Yogendra, I apologize for geeking out a little bit, but here we go. Couple things. I want to make sure I'm hearing you clearly on what the monocyte situation is. Is it that the monocyte is scavenging other cells who are continuing to be infected, and it's just concentrated in the monocyte, so you're finding it in the monocyte, and the monocyte is the culprit in terms of the more serious inflammatory kinds of phenomenology around the infection? Or is it strictly an ongoing infection directly of the monocytes, or does it even matter? I mean, it doesn't, because either way, the monocyte's sort of going out into the periphery of the vascular system and doing its thing. A. B, interesting sort of clinical observation about vasculitis and why steroids might be useful. And then C, the vaccine. Are we seeing some sort of mini COVID from the vaccine through this same exact mechanism? So I hope that's not too many questions in one, but I want to get them all out before I forgot them.
Well, what was brilliant about that description is that you kind of encapsulated everything that's going on right now in our world at IncellDX and what we're faced with. The answer to your first question is we were actually able to use technology to sort the exact cells that contain COVID protein from long hauler patients, and then take those cells and prepare the protein and do protein analysis to confirm that they indeed contained the S1 protein. In addition, we were also able to look for COVID RNA, and in only one instance out of the 20 to 25 long haulers that we had enough immune cells to study in depth, did we find COVID RNA, and she was 15 months out.
Wow.
So we've now extended the range of where you find COVID RNA, at least in one patient, but there was many patients who had this ongoing protein expressed in their non-classical monocytes. Now, the intermediate monocytes, which are similar to the non-classical monocytes, in the past we published papers that we could infect them with HIV, we could infect them, or they were infected with HIV, they were infected with hepatitis C. And actually, those intermediate monocytes are responsible for Zika and dengue fever getting into the brain. So, in terms of where you start looking, I did an article years ago about, being a virus hunter, and that's exactly what we are. And, my go-to in terms of virus hunting is essentially these scavengers a virus that express the appropriate receptors. So that's how we latched on to, the monocytes as being a potential source for this virus. Now, you brought up a great point about vaccines, because we are seeing patients 2-3 months out from a vaccine who never had COVID, who are having long hauler type symptoms. And as Ram will attest to, we've probably have 1 to 200 patients enrolled in our COVIDLonghauler.com program that aren't true long haulers, but are having long hauler type symptoms after the vaccine. And I think the one thing so far, and again, we're just in the beginning of starting to study these patients, is they don't have the vascular inflammation markers that the long haulers have. The soluble CD40 ligand, which, back to your point about platelets, is a marker of platelet activation. So yes,
wait, which ligand? PD40?
Soluble CD40 ligand, SCD40.
So I keep reading about the heparin thrombocytopenia ligand, the PD4 or something it's called, right?
Something like that. But
yeah.
we find, and it, there's great reports in the literature about, how sensitive soluble CD40 ligand is for platelet activation, and VEGF, which we've talked about before, vascular endothelial growth factor, are both markers of vascular inflammation. And the soluble CD40 ligand pulls in the platelet issue and the potential clotting issue that I think that you were alluding to. So we don't see those markers, at least so far, in the post-vaccination cohort that are having long hauler type symptoms. And we've treated several of them, and we've treated them successfully. So, from my point of view, the vaccine is still an important part of attacking this pandemic. And yes, it should be expected that there's going to be side effects and issues when you're vaccinating that many people. The fact is, so far, we're able to manage these individuals who have this inflammatory sequelae post-vaccination.
And Bruce, I'm going to ask you to hold the steroid part of the story, because I keep thinking, that's where I like using steroids, but I'm going to ask that. But first, go to Dr. Yogendra. Dr. Yogendra, these folks that show up at long hauler 3 months after vaccination, is it developing 3 months later, or does it develop immediately following the vaccine and you're just seeing them 3 months later, typically?
It's a great question, Dr. Drew. I would say a good majority of them, actually, I just did a telemedicine this morning, and half the patients were this post-vaccination group. Most of them are developing this right after, and usually you say, okay, about a week or two, you might have some symptoms. That's sort of expected. But these are 3-4 months out, and they're persisting. The brain fog, the fatigue, the POTS, the sort of the dysautonomias, and all these things that you hear from long COVID patients. You're hearing it from this post-vax group. Now, it makes it a little bit of a challenge, as Dr. Patterson was talking about. We are looking into this to understand mechanisms and not sort of jump to conclusions and start making outlandish statements, because, quite frankly, what we're trying to do is see how many of them had COVID before and how many of them were asymptomatic. And also, I know Dr. Patterson will allude to this, or he's talked a lot about this, is the PCR, and just how it's just not a very good test, even though it's considered the gold standard. There's a lot of false results on that. So you'll have patients that'll say, well, I had a negative PCR. So, in studying these group of patients, we have to be careful in sort of getting patients that we know that didn't have COVID before, have some, whether it's a T-detect or a nuclear capsid. I think, we've been talking about sort of criteria in studying these patients. But just going back to your question, most of them are usually after the first vaccine, and it's all 3 of them.
It develops immediately and just persists.
Okay. Moderna, Pfizer, and J&J.
So, okay. Those are the 2 big ones, not so much with Moderna?
Oh, no, all 3 of them, Pfizer, Moderna, and Johnson & Johnson.
So Dr. Patterson mentioned something about the vaccine side effects, which I've seen a lot of really peculiar side effects. I have a growing concern about the opacification or the lack of clarity, lack of transparency that we're providing patients in terms of giving them the numbers about the spectrum of vaccine reactions, which is small. It's small. And I think an average person can understand that out of 150 million vaccines, 10,000 or 30,000 or whatever is small. I'm getting concerned about informed consent. I'm getting concerned that people aren't given the general, in terms of the vaccine hesitant group, I feel like they need information. We're not giving informed consent. We're just getting consent. I mean, I just signed, I took J&J, and I noticed that I just consented. There was no information provided to me, and there's really no place to get good vaccine information right now. Dr. Yogendra, do you have any concerns about the ethics of and I'm going off topic for a second, Dr. Patterson, don't worry, I'll go back to the science in just a second. But A, lack of informed consent, and B, people like me that have high levels of antibodies post moderate to severe COVID, unnecessary medical procedures.
It's a great question, Dr. Drew. I think one that we've opined internally also about this. I don't necessarily know we should be. I've got friends of mine that had COVID, and they've come to me and said, should I get the vaccine? I said, well, do you have antibodies? Do you have high titer levels? If you do, I don't necessarily know you should be getting the vaccine. It still doesn't make any sense to me. Obviously, Dr. Patterson can also jump in. I know he sort of feels, we've talked a little bit about this, is should we be vaccinating people that had COVID and still have high levels of the antibody titers? I don't know. It's very puzzling to me that
I can tell you, as I think back to where my head was at when I took the vaccine, I probably would still take it because I had a certain amount of dread and fear of a recurrence, even though I had high antibody levels, because we don't really know what high antibody levels mean, really, in terms of recurrence. And so we do know what the vaccine profile is in terms of protection. So personally, I would have taken it anyway. Even if I had concerns about safety, I still would have done it. I would have done it for two reasons. One, I don't want a recurrence. No, thank you. And number two, I think we have an obligation to suppress viral replication. We have a community obligation to reduce the risk for mutations. You agree?
Well, the thing, that Dr. Drew, is, when we were talking about you're absolutely right, and I do agree with you.
Yeah.
And I think we're going to the vaccines and sort of information out there. I think it's a little bit disingenuous to tell people, well, the vaccine is safe. I think we should say, so far, the studies have shown that it is. We've inoculated millions of people. The data from the trials show that it is safe. However, we don't know the long-term effects of it. There will still be a lot of investigation. It's still in an emergency use authorization. I think people are not stupid. I think we should be telling them that.
I think the public health officials have treated us all the way along like we're stupid. I think that's been the general demeanor of public health. And two standouts for me. A, you can't handle the truth is number one. And number two, no risk-reward analysis for any of their decisions. They just did not make risk-reward analyses ever. I don't know. Even to this day, I don't know if you're aware, Dr. Patterson, you're probably aware, in California, OSHA just voted to maintain distancing and masks in the workplace indefinitely based on no science. My question was, if you're going to interfere with the medical caretaking of your employees, what about meningococcemia? What about other viruses? What about, there's so many other things to be concerned about. You're going to involve yourself in the medical care of every one of your employees. That's disgusting. And they can't see anything but COVID. Dr. Patterson?
But that includes influenza. 50,000 people die every year from influenza, and we don't have those kinds of mandates during influenza A season in the winter. Or respiratory viral season in general, wherein maybe that's something we do in the winter. In terms of employee health, is recommend precautions, mask wearing. During the height of respiratory virus season. Come November to February.
Have you guys had the COVID vaccine, both of you?
Yes.
Bruce?
Yep.
I got a feeling, by the way, Dr. Walensky at the CDC did not vaccinate her 16-year-old son. She is every opportunity she's had to say, well, I vaccinated my son, but I'm still holding him back from camp. She has obfuscated that response in every time it has been brought up, which to me means she has not vaccinated her son. She even went so far as to say, my son has asked for the vaccine And then she doesn't go on to say, and he got it. She doesn't say it ever. I've looked very carefully at her responses to conversations about the COVID vaccine. But anyway, let's get off that for a second. Bruce Patterson, steroids. I took Decadron during COVID. It's very clear to me I had a cerebral vasculitis. I kind of knew it at the time. It felt like a head injury, felt like a traumatic brain injury, some kind of diffuse something. And I figured it was probably not diffuse infection because, I don't know, I feel like I've had that before. I've had diffuse viral infections before, and they felt different. As such, I was enthusiastic when my physician suggested Decadron. I thought it was a good idea. It did seem to help a lot. What is the role of steroids in long hauler? What is the role of steroids in acute COVID? What is the role of steroids with vaccine therapies? Where do we go with that?
Well, I've gone on record. I mean, having treated other viral infections, especially shingles, is so widespread, and I am always hesitant to use steroids in the absence of a antiviral, right? And we don't have great antivirals in COVID. We have some. If it was shingles, you could think about acyclovir plus steroids. I mean, that's just classic, good medicine. And so the one thing I worry about is, yes, you feel better, and when you have severe symptoms like you did and others, the steroids are preventing, the tissue damage caused by the
and by the way, it was concurrently 2 days later from initiating steroids, I was given monoclonal antibodies. So there was an antiviral intervention.
Which is good. I probably would have given them concurrently.
Well, you don't get to choose. You line up and you wait. You know what I mean?
That's right. But at least that is a strategy that I could be on board with.
Yeah.
I mean, obviously my fear is what is causing long haulers, and are we creating long haulers during that acute COVID infection? Now, what is against that is the fact that a lot of long haulers didn't have severe disease. They had asymptomatic or very mild disease. But what we saw when we looked back at, mild to moderate and severe COVID infections was that they had immunologic disease, and they were given therapeutics. But the question is, and we found that these viral reservoirs in the monocytes were being established at that point. And, obviously we're prone to set up a long hauler situation.
So let's make sure, let's put a little lantern on that, which is, you're saying steroids seem to be increasing the risk of long hauler.
Good. Yeah. I mean, we're still investigating what if there was a setup for long haulers during acute infection. And in fact, in our bioinformatics model paper, which should be coming out soon, we found that, and what cut into the sensitivity of our long hauler. So our long hauler index had 98 to 99% sensitivity for identifying long haulers, which was amazing, using machine learning and AI. And our specificity was right around 93%. So there was a 7%, kind of false positive that cut into our specificity. But when we looked further, it was actually some severe COVID patients were registering on the long hauler index, which all the other acute COVID patients, mild to moderate, severe, critical, didn't register on the long hauler index. But there were 7 severe patients who not only registered on our severity score, but also registered on the long hauler index, which suggested to us, and we put this in the conclusion of our paper, that possibly those individuals, we possibly identified individuals who were going on to be long haulers because of their immune profile during acute COVID. So that's an active area of investigation. And once we get into that a little deeper, we will start to look at the different therapies they might have received in the hospital.
Got it.
Are some of the therapeutic approaches contributing to people being long haulers, or is it just a function of their particular immune response?
Got it. Let's talk a little cytokine for a minute. Dr. Yogendra, what is the takeaway from cytokine other than the CCR5 receptor on the non-classical monocyte? Is that correct?
Yes.
Right.
Yeah, it's it's we've talked a lot about. This is a heterogeneous, even though there's the long hauler index. It's almost like a fingerprint that we can identify or classify someone as a long COVID or not. But this is what's very interesting now. I think in our team, we've looked at hundreds of blood samples, and we've, as Bruce just mentioned, we've got close to 5,000 patients that are registered in our program. Having looked through now hundreds of blood samples, it's interesting how the vascular inflammation is playing a very interesting role, especially the role of VEGF and SCD40L.
And those are the two. You mentioned the CD40 ligand before and VEGF before, and those are good indicators of endothelial inflammation, correct?
Correct.
Yeah.
And we're starting to see a very interesting correlation between the brain fog and the elevations in VEGF. I mean, it's I think something like 79% of patients that have elevations that have brain fog have.
Yeah, so I had a lot of brain fog, and Dr. Patterson, if you remember my profile, you did a cytokine profile. My VEGF was off, and if I remember right, my Rantes was off too, right?
It was.
Yeah,
yes.
so Rantes and VEGF. Is that a typical neuro long hauler symptom?
Very typical, and again, the CCR5 antagonists have been brilliant in relieving brain fog and tinnitus. Lately, probably in the last 4 months or so, we've seen a lot of long haulers with tinnitus.
I'm here to tell you. I still have it.
It's amazing how Maraviroc, which is what we've been using, potentially leronlimab when it gets approved, but the CCR5 antagonists really attack brain fog and tinnitus, and it's so reproducible. And typically those are the symptoms that really bother people. I think they can deal.
And the fatigue. Those are the three.
And the fatigue.
And the fatigue. But back to just me as an N of one, my case, fluvoxamine had a marked effect on my fatigue. First of all, my tinnitus immediately, not so much the brain fog. Does that fit? What do you make of that?
That's typical. And then of course, VEGF also contributes to peripheral neuropathy-like symptoms. So we get a lot of that, and of course that's relieved by the CCR5 antagonists, which bring down VEGF. So
is fluvoxamine, the sigma-1 system, related to CCR5?
No, it's not, but it's very capable of bringing down intracellular cytokine levels. So I think that's why it's been effective. And it's really, so we've gotten to the point where we can say, well, for instance, IL-2 and TNF alpha, when they're elevated, IL-2 is almost always elevated as part of the long hauler index. In long haulers is always related to fatigue. And so, fluvoxamine has done a really good job of bringing down IL-2. The CCR5 antagonists bring down TNF alpha, VEGF, Rantes, and IL-6. So, we've gotten to the point where we have this armamentarium of, say, 5 to 10 drugs that we prescribe. And after studying now, I would say it's 1,000 or over 1,000 different profiles. I mean, we can predict if you have this profile, and this is outside the long hauler index, but if you have combinations of some of these other cytokines, we know what to give because we know now what drugs tend to bring those particular cytokines down, so that we are able to bring their complete profile in addition to their long hauler index back to normal. And that's really the goal of what we're doing.
So Ron, back to the clinical, what is your impression of what you're doing? Are you doing a certain profile when they walk in? Do you have certain expectations of what you're going to use? How have the applied therapeutics ended up affecting patients?
I look at it as three different mechanisms or three different pathways that we're sort of targeting from kind of what Bruce and his research have shown. One is we're looking at the mobilization of these monocytes. So whether it's with the CCR5 antagonists, and very interesting, we've been talking about, and even on some patients, putting them on propranolol, a beta blocker, very low dose, because in the literature shows that the monocyte is mobilized when you have high levels of adrenaline, and there's publications that actually show that beta blockers prevent the mobilization in exercise immunology. So that's one pathway that we're targeting. The other one is endothelial inflammation. And as Bruce mentioned, the role of fractalkine, the fractalkine receptor, which it's been studied extensively in ME/CFS and in multiple sclerosis, and looking at the different pathways on there. But there are medications.
Atherosclerosis.
And atherosclerosis too, yeah. And which, on that point that Bruce just mentioned, statins. I mean, the patients always come wanting us to come up with some experimental drug that's out in, Mexico, or some esoteric, concept. Sometimes we have to think simple. It's about medicine's very simple, about understanding mechanisms and pathways. So some patients are in a combination of a beta blocker, a low-dose steroid, a statin, and a baby aspirin, because we're targeting three different pathways. One is the mobilization of those macrophages. Two, we're targeting the endothelial inflammation. And three, we're targeting the overall inflammation that's taking place. And this is why we've been talking about a cocktail of medications as being the solution for many of these patients. Some of them they'll take high-dose steroids and say, I didn't really do anything. Or we took Ivermectin, it didn't do anything. But it's about combinations and targeting the different pathways. We think it's the overall solution. And quite frankly, a lot of patients are benefiting from that approach.
Is there a sort of a empiric go-to if people don't have access to the kind of, extraordinary testing you guys do? Let's just say, for whatever reason, you don't have access to it. Bruce?
Well, I think, given the heterogeneity in these patients, and like we've said, the stories and the immune profiles are all other than the Longhauler index, which is consistent. The other 11 cytokines that don't make up the Longhauler index are all over the place. And so, we've had some patients who are like, I can't get tested, quick enough. I'm really suffering, and it's really hard. I feel like I'm attacking it blindly when I don't have the data to drive.
But that you're a pathologist, you're kind of used to data. We're on the medicine side, we're used to attacking things blindly.
Yeah, well, I mean, but back to your point, yes, we would start off very mildly, ivermectin, 5 milligrams of prednisone, and 10 milligrams of prevestatin would be a combination that we would use if we didn't know the complete profile. We might start with that and say, okay, go on this for 2 weeks, and in the interim, let's see if we can get some testing done to say, are we in the ballpark, or do we have to add or subtract something from that?
And what about? But I understand not using Maravirac until you have some data. What about fluvoxamine? You said it generally lowers cytokine. Want to throw that in there?
You could swap out the prednisone for fluvoxamine, and to go ivermectin, fluvoxamine, prevestatin.
Well, I noticed you guys were using a lot of ivermectin, fluvoxamine early on. Was it useful?
We still are. Yeah. Patients are definitely responding to that. And then these are patients who didn't respond to ivermectin alone.
Yeah.
But as soon as we added the fluvoxamine, we get some sort of synergy going on, and they tend to respond.
There's a bit of conversation in the literature, out there about what the optimum dose of ivermectin is. Are you messing around with that at all?
We did, and I think in general, and Ram can also add his thoughts. I think in general, people were taking too much. So we go to an every third day regimen, depending somewhat on body weight, somewhere between 6 milligrams and 12 or 15 milligrams every third day.
Is that going at the monocytes? Is that the idea?
What it's doing is obviously as immune modulatory effects. I also think it affects the ability of these cells to present antigen and potentially even block maybe the S1 protein binding to ACE2 receptors. But that remains to be seen. But the fact is the real world data that we have using it has shown that in combination it's been working beautifully.
Ram, anything to add to that?
Yeah, no, it's these combinations, again, like as Bruce said, we're targeting different pathways, and we get these questions all the time about what are the protocols, what are you doing, different groups, we're working and collaborating with the FLCCC doctors. We've built this whole network of physicians all over the country, and literally on a daily basis, just more and more are coming out and understanding the research, which is fantastic, which goes back to what I always mention this on social media, just what you had told me months ago about doctors need to talk to each other. And along that point, you about the vaccines, I just want to jump into something. We don't treat our primary care doctors with the respect that we should. I've heard comments where, well, why are you telling those primary care doctors those things? Well, they should know this research. We talk a lot about this translational medicine, but quite frankly, when you look at the studies out there on long COVID, they're still doing studies on they're doing surveillance and surveys and epidemiology. And we've got literally tens of thousands of people that are suffering right now. And we want to get that information. This is bigger than Dr. Patterson and myself and Dr. Parikh. We want to get this information to the clinicians, to the primary care doctors their practices are getting inundated. These people are still self-medicating themselves. So we got to get this information out there and explain to them, show them the science, and then a lot of them are coming on board, which has been very encouraging. But to the point you mentioned about access to the testing, we are not just a bunch of researchers and scientists just sitting and opining over situations. We understand public health. We understand that people lost their jobs. There's the financial distress from the pandemic. We understand the healthcare disparities, people in inner cities, people that don't have access to quality healthcare, don't have access or money to get these testing.
Right. And
in about a week or two, we are launching, well, we're not, but it's the patients of ours. They're so supportive. We're the Etsy of long COVID. I make a joke with that, but I'm serious about it. This is a DIY project that's been supported by hundreds of our patients. And these patients got together and they're starting a GoFundMe page now we can start to get the testing to inner city people with healthcare, with all the healthcare disparities in the country. This is not some sort of specialized testing that should be only for elite or the wealthy. It should be open to everyone. And, we've done a lot of pro bono work. We don't make announcements about that because that's just not who we are. But the reason I jumped in with Dr. Patterson is, you guys see him as this brilliant scientist, and he is. He's probably the smartest guy I've ever worked with, but he's a humanitarian, and everyone at Incel, that's what I wanted to be a part of. And look, we don't have a PR, we don't have media, we don't have anyone, but you know what we do? We have hundreds of patients that are they're our spokespeople because they are getting better. And even, and look, there's a handful of them that we do need to do a lot more work, and we do need to do a lot more research. And I don't want to come here and say, yes, 100% of our patients are getting better. There's a handful of them. We are trying to crack the code, try to figure out what is going on. But here's the thing, we give them hope every single day. This is a 24/7 job, and we just let them know, don't lose hope. We've got something. We got new data. We got new medications. We're interfacing with other physicians. And I think the important thing is I know we're talking about the science right now, Dr. Drew, and that's interesting. Publications are interesting, but we're dealing with human beings and human lives, and we're trying to bring awareness to our public health officials. And if we're creating this program, and I think we're just so grateful to where we are from where we were 6, 7, 8 months ago.
Yeah,
And this
it's
is a
amazing.
concept.
It's amazing what you guys have been able to do. And you're right, primary care, the behavior of primary care in this pandemic has been astonishing. I didn't realize how many of my peers are employees, and they behaved like frightened deer during this whole thing. And I hope they step in and start practicing medicine again. And as such, they will be the ones seeing primarily most of these patients at the front line, and they need to know about what you guys are doing. That's one point. Second point is I want to share with you guys, again, my own personal long hauler thing to add to the mix of thinking. As I said, fluvoxamine within minutes helped my tinnitus, which did then come back. It didn't go away. It kind of came back at a lesser intensity, and I still have it intermittently. And interestingly, so much as a sip of alcohol makes it worse, which is very interesting. And my brain fog stuff, which was towards the end hard to characterize, the experience was like there was something that needed to be worked out, almost like a joint that needed to be exercised or something.
Right.
And so I started thinking, well, is it motoric? Should I learn how to dance? Should I go back to the piano? And we're going to Greece in a few weeks, and I thought, I'll try to learn a new language. I'll try to learn Greek. And within 2 weeks of starting that process, my brain fog lifted almost entirely. Isn't that interesting?
Right. Very interesting.
Yeah.
As far as alcohol, which is a vasodilator, I think, with long haulers, we've seen they have migraines, they have headaches. And a lot of that, when the blood vessels get inflamed, they tend to dilate. And I think, alcohol certainly does that on its own, and it may be just exacerbating, some of the residual, symptoms that you have. So I think that was a very interesting observation that you had.
Yeah, it's wild. Dehydration will do it too. Sometimes exertional exercise, though not necessarily. Kind of weird.
Well, we see that a lot.
Yeah, but it's mostly gone, which is, I'm grateful for that. All right, where we've sort of done a survey. Where would you guys like to educate people about next, or should we take questions? What do you guys want to do? Opinions? Meaning you guys.
I can maybe we take some questions. I think we talked enough of the science, right, Bruce? I don't know if you want.
Well, there's more to say. I mean, the science keeps going. I got some more questions. We didn't.
And it always will go. And I think, but I think it's important because I do think there's an education element that needs to be put out there. So, and we're always happy to answer questions.
Well, it's in terms of education. I mean, when COVID started, I knew what cytokines were. I knew the basic pathways. I'd never heard of RANTES. I really didn't know what that was. I'd kind of maybe heard of CCR5, but didn't pay attention to it.
Yeah.
So awareness of the physiology is way up. And so when you are able to describe people's pathophysiological profiles in cytokines, I think people kind of know what that means now. And the fact that you have some ability to do something with it is I think catches people's attention.
I think the silver lining in that is also that once we get control of sort of this long COVID program, I mean, in fact, we may do it before that, but we're rolling in post-Lyme, chronic fatigue, fibromyalgia, other very similar conditions that have similar symptoms.
Hey, listen, I imagine a day when you start looking at vegetative depressions of all stripes, that there may be a big inflammatory component to that. We don't, right?
Yeah. I mean, the one thing COVID is teaching us, much like HIV taught us about molecular biology, molecular genetics, I think that impacted cancer for the next 20 years. COVID's teaching us about the immune system. And I think immunology is going to be at the forefront of biotech for the coming years, because at the end of the day, that's our strongest weapon, both against cancer and against pathogens. And as we face more emerging pathogens, and I've said this numerous times, we have to start stockpiling drugs like the CCR5 antagonists that are agnostic to the pathogen, but are ways, much like the PD-L1 inhibitors in cancer, they are ways to enhance the immune system to fight off, the pathogen like it fights off the tumor in a non-pathogen or non-tumor specific way.
So PD-L1, those of you who don't know, PD-L1 inhibitors is it's a mechanism that allows the cancer to escape our immune system. We unlock that so the immune system can see the cancer again and start attacking it.
Correct, but it's not like it's a lung cancer tumor.
Right. Though it has some specificity, because some tumor, so.
Of course. Yeah. I mean, not every tumor expresses it, and every tumor expresses it to a different level. But the fact is, they all know how to make, for the most part, they know how to make, PD-L1
and hide,
and that allows them to be invisible to the immune system, essentially.
Exactly. So you mentioned the CCR5. I guess it's technically an inhibitor, so that leads us into Maravirac. Do you want to? We haven't really specified where you're using that. How do you know where to use it? And should it be used in sepsis and things like that too? That's what occurs to me.
Well, I mean, it's starting to come into its own, and I think it's really going to be the next big immuno-oncology drug as well, because it inhibits the inhibitory aspects of the immune system that shut off what you're bringing back with the PD-L1 inhibitors. So I do think it's going to play an important role with, the PD-L1 inhibitors in enhancing and prolonging the immune response. And Maravirac is just one of many. There's Maravirac, there's leronlimab, there's Cencravirac, which is also being used in COVID. It's an AbbVie drug. And there's Orion OB002, which is going to be starting in cancer soon. So this target is coming into its own. And it's coming into its own because, like I've said many times, it's like the quarterback of the immune system. It really directs where immune cells go and where immune cells are needed. And we can manipulate that. Do we need more? Is it overzealous? Do we need less? It reprograms macrophages from pro-inflammatory, making cytokines which cause all kinds of damage, and are pro-tumor and pro-infection, to more of an effector macrophage that'll help, clear the pathogens. So I do think CCR5. The target is going to be, and of course, Rantes is one of the ligands for CCR5, as is MIP1 alpha, MIP1 beta, which is CCL3 and CCL4, among others. And that mechanism, in terms of controlling where immune cells go, is extremely important in not only COVID, but it's important in cancer. CCR5, it's almost like a red herring that CCR5 happens to be a co-receptor for HIV. We're finding, I started working on that in the mid-1990s, but I think over the intervening years, CCR5, we've understood its role in the immune system. And, like I said, as far as cancer is concerned, maybe other pathogens like COVID and others, maybe sepsis. I mean, you can look in the literature, and there's probably 60 indications that involve Rantes. And of course, because it involves Rantes, CCR5 inhibitors would be effective therapies. So yeah, absolutely. I think this is just the beginning of an era where CCR5 antagonism is going to be critical in many disease states.
And Dr. Yogendra, you taught us early on in the pandemic about CCR5 and Rantes, and the fact that it's sort of the pheromone of the immune system. It sort of sends out sense that the cells follow. And you had a lot of enthusiasm for Maravirac early on. Where are you with it now?
Yeah, no, I think what Bruce has been researching is it's just fascinating, because we've talked internally too about the next steps, what we are learning with long COVID and the role of CCR5, just whether it's the operations of putting together the clinical side of things, and also the science behind it, is to go into a lot of the neuropathic pathways, the pain pathways. You see CCR5 signaling being mentioned about it, the role in ME/CFS and fiber, all these other sort of the things that are sort of puzzling us, and we still haven't had a good handling of it. The question is what is the role of CCR5? And that is the next venture, the next scientific thing we're going to pursue. And again, literally on a daily basis, we're getting a deeper understanding. Obviously, Dr. Patterson and all the immunology and the rest of our team and the clinical things. End of the day, it's about the translational medicine thing. It's about taking this research today and making people's lives better. That's what we're in the goal for. We're not about, okay, we can talk about CCR5 all day.
Yeah.
But what can we use Maravrac in neuropathic and cancer pain, in the ME/CFS community, in the post-Lyme, the post-West Nile.
Yeah.
So I think there's just huge potential there. It's been discussed, but it's not been used in a clinical setting. And I think that's where the potential lies for the CCR5 signaling.
Bruce, on my stream here, there was a question about what you were talking, you guys were both talking about PCR as not being particularly the best test for COVID. What is the best test for testing whether or not you've had COVID?
Here's the deal. I mean, PCR is the best test for COVID, but people have to understand the performance metrics.
Right,
and being
right.
from lab medicine, it's very clear. There's three phases to diagnosis. There's the pre-analytical, which is taking the sample, the analytical, which is applying the test or the assay, and then there's the post-analytical, which is the analysis, and sometimes that involves bioinformatics. My point early on in the pandemic was, and we've dealt with this with respiratory viruses for years, the emergency rooms all wanted lateral flow devices, which are essentially pregnancy tests for seasonal viruses, influenza, RSV, etc. Why? Because they could get a result in 10 minutes. But we used to call them the 80-80s. They had 80% sensitivity and 80% specificity, and you were dealing with 20% false positives and 20% false negatives. And that was a big issue, because how do you triage patients in a hospital based on that performance? It's impossible. You would almost rather have a test that was 100% sensitive and 20% specific, like the first HIV test and like the HPV DNA test, where you could come back with a confirmatory test, but your sensitivity would minimize the number of false negatives. The whole problem with respiratory virus testing is the sample. Sticking a swab up your nose is probably the leading cause of variability in test performance. And in pathology laboratory medicine, we talk about analytical performance, which is how good is the assay. We know PCR, the analytical performance, close to 100% sensitivity, close to 100% specificity. It's amazing analytically. But it's what you put into that determines clinical sensitivity and specificity. So the companies always love to talk about analytical sensitivity and specificity for good reason. The results are damn good. But what you're dealing with as a clinician in terms of treating and triaging patients is clinical sensitivity and specificity. And that includes literally driving up to the tent that is a draw station to take the nose sample, putting it into a viral collection media. Where does that tube sit? At what temperature? How long does it take to get to the lab? How long is it processed to actually get it into the assay? That all contributes to overall clinical sensitivity and specificity. And that is where you see this discrepancy from analytical sensitivity and specificity. Now, there's all the different tests, whether they're antigen-based or PCR-based, have different analytical sensitivities and specificities. And clearly, PCR is probably the best assay in that regard. But it's only as good as what goes into it and how deep you take that swab, how long does it take for that, swab and that media to get to a lab. All these things are factored in. And when you factor all of that in, you still have, I said on the news over a year ago that I would expect there to be a 15% false negative rate with COVID testing. And there was a study out of Louisville that said it might be as high as 40%. Nevertheless, there is a significant false negative rate. Not so much a false positive rate, because that comes down to the assay and maybe is there contamination or crossover. But so the positive tests, the positive predictive value has been pretty good. I think the negative predictive value is where it's lacking. So it's difficult to say if somebody had a negative PCR test, and everyone's like, oh, that can't be because it's PCR. Well, they're thinking about analytical performance. Clinical performance, yeah, there's a problem, but there's probably a problem with all tests,
right?
Because it all depends on.
There's also time course of the illness. I mean, I was negative in PCR for 4 days, and day 5 I turned positive. And there's accuracy. What's the probability that the positive is a true positive, and based on the clinical presentation? So a lot going into this that people need to think. How about immunological profile? What if somebody wants to see whether they've had COVID, and then the corollary question is, am I immune? There's 2 different questions. Do you have a recommended test for that?
Well, you know what? Again, there's companies, Innovative Bioanalysis, who runs one of the labs that runs our cytokine assays. They have a very sensitive quantitative neutralizing antibody assay that measures neutralizing antibodies to COVID and whether or not you've been exposed. The one big missing part, and there's a good reason for it, is cellular immunity. It's not just humoral immunity and antibodies in terms of having protection against viral infections. It's the cellular immunity, and those assays tend to be difficult, especially clinically, because there's a lot of variability. There's a lot of differences in terms of methodology. They were difficult when we were studying HIV. There's a good one called, quantiferon for TB, where we no longer do the needle under the arm. We basically test in vitro whether or not you have cell-mediated immunity to tuberculosis. But, those are long, expensive, and somewhat variable tests that to date just aren't being used routinely in the clinical laboratory setting.
Right. Somebody's asking the question, let me read the question. Can you explain antibodies? What is high? What is low? My doctor didn't have any answers. Mine is 6.33, and anything above 1 says you've had it. That's more of a qualitative test than a quantitative test.
And again, it's also a commentary on interpreting lab data.
Yeah.
Each laboratory has their own normal range. Each laboratory has done their own validation. Whenever you talk about quantitative assays, I always say you have to go to the same lab to follow something over time quantitatively. For instance, in males, if you're going to have a PSA, the urologist knows he's not going to send your PSA to one lab one time and send your PSA to another lab the next time. They're just going to be different. That's the nature of laboratory medicine. That's why I had a job. That's why I have a job, is because I was trained in laboratory medicine, and it's our job to ensure that the test results are accurate. And like I said, doing it at 2 different labs doesn't ensure, at least on quantitative results, that you're going to get the same result, or you can follow that result over time.
On the Clubhouse audience, I wonder if any physicians, if there are any physicians in the group, have any questions, you would raise your hand.
Rob Cobo is a physician.
And where is he? Is he raising his hand? No.
I don't know. He's the only physician I've seen. He has a white coat on. He's the fourth one on the top row. But I don't know. He's been here since the beginning because he's on the top row.
Rob, any question? You can raise your hand. I'll bring you up here if you have any questions, if this makes sense to you. I want one more question. Ram, I'm sorry I'm cutting you out of this one a little bit. I'm still, this vasculitic component of the illness, I felt from the beginning this was an endothelial disorder. Mm-hmm. And I'm also convinced that the platelets are somehow not just aggregating and activated, that they're somehow complicit in the inflammatory component. Do we know that relationship yet?
You know what platelets make? Activated platelets make?
CCR5.
RANTES.
Okay.
Which, as we've said, to try and make it more simple, that's the honey for the immune cells to be attracted to, like a bee. So, yes.
And then, just so I get the physiology, so the platelets are activating. We know those ligands are up. There are strange things like megakaryocytes being seen in the periphery. I don't know what that's all about. Maybe it's the consumptive platelet coagulopathy or something related to that. And the CCR5s, the RANTES is being released. The monocytes are there, the non-classical monocytes. Where is the endothelial damage happening? Or is it a damage?
Well, it is a damage, and it could be either direct viral infection, which has been shown in active COVID, or it can be as a function of, attracting, COVID protein either through the cells that we identified, the S1 protein, and then all of a sudden they become a target for the immune system. So, it's probably multiple factors which target the endothelial cells. But early on in acute COVID, it's also, direct infection.
I wonder, you guys have had some success, you said, with Pravachol, right? Is the apolipoprotein system involved in this somehow too? Because that's another way to hit the endothelial surface.
It is. We haven't looked into that with any great detail. We wanted to get something on board, and that's obviously why we went with the pravastatin. And we wanted to do something that had a minimum of side effects. Like a lot of the statins have lower body weaknesses, and that's the last thing long haulers need is another symptom to
that's for sure.
Exacerbate what's already going on.
Ram, do you have anything to add to this? I've excluded you from the conversation for the last 5 minutes. I apologize.
No. And this is always a pleasure for me when I get to listen to Bruce talk, because there's always a lot of information, even for me too. So it's great. But no, just to echo what Bruce mentioned, what you also mentioned about the sort of the potential for the cholesterol, the LDL, and it's, there's a couple of these long haulers that do have elevations in their LDL. It's very interesting. That's obviously something to do more investigating in. So we might have could there be some sort of obviously endothelial issues taking place? There are inflammation.
There is. I know there is. I know it. I've known it from the beginning.
Right, and I think it's interesting. I was just talking to a primary care doctor this morning out in. Well, another one that's actually put some of her long COVID patients on statins, and she said, "I'm having these patients are responding really well to the statins," because I was talking to her about putting one of her patients on it, and she just looked at me. She goes, "This is what I've been doing." So definitely, again, it's
by the way, let's just shine a light on that for a second. Isn't that interesting? This is what I was looking for from my primary care colleagues, which is improvisation based on judgment, where they result in treatment interventions that might have some effect, and lo and behold, they do. It's the opposite of what they were doing early in this pandemic.
Well, it's also being driven by identifying the mechanism, Dr. Drew. I think it's one thing to try something. It's another thing to try something because you are understanding the mechanism and where that particular drug may fit in terms of therapy. And I think I think we're at that point right now where we can allow the data to drive, the various combinations that we've been talking about. And I just have to say right now, I mean, Ram and his training in anesthesia he is the man putting together these combinations. I mean, he understands pharmacology almost like a clinical pharmacologist. And
I'm not surprised. Yeah.
It's been a great collaboration because, I can sit there and spit out a pathway, and he'll come back and say, well, why don't we try this? And sure enough, we've created this panel of, like I said, 5 to 10 drugs that we use in various combinations. And, Ram has been instrumental in really putting those together based on the pathways that we've identified at InCellDX.
Dr. Yogendra, want to comment?
No, again, as Bruce mentioned, it's we just got an incredible team, and putting
you guys
together
have done a lot in a very short period of time. It's been a fire drill.
We have to.
Yeah.
It's almost been I joke with Bruce that my understanding of immunology and virology might be more than anesthesia and critical care medicine. The past year has just been an absolute pleasure.
I watched your learning curve. I watched how it happened. because each time we've talked, I've seen the expansion of your understanding of these things.
Mm-hmm.
Yeah,
and you brought me, you dragged me along with you, and I appreciate that.
Yeah, I think it's we're creating a movement here, Dr. Drew. I'm not even trying to be using this sort of as an hyperbole or sort of make a statement, but it's about changing the way, and you too, Dr. Drew, have been instrumental in my career and really influenced our approach. Because when Bruce and I we were talking and trying to work with other doctors,
neither Bruce nor I have such command of the GIF. But go ahead.
Yeah. Well, the thing is, it's we all learn from each other, and I've learned tremendously from Dr. Patterson and everyone at InCellDX, and I also have learned a lot from my discussions with you. I think we all have to take a humble approach and try to learn from each other, and that's not something that's done much in medicine. Is really respecting each other and bringing our insight, but at the same time listening and learning. And I think the most important thing at the end of the day is that we are here to take care of patients, and we're here to work together. We have a team that has zero egos, that we work seamlessly. It's just been such a pleasure. I mean, working with Bruce has restored my faith and the reason why I went into medicine. I was ready to get out of clinical medicine before I met Bruce.
Nice. That's a big deal.
And
you're not alone,
it's
by the
huge.
way. A lot of physicians are feeling that way.
Exactly. I was burnt out. I'm ready to get out and join the administrative side of things.
Yeah.
But Bruce reminded me why I got into medicine in the first place. And also I got to give a lot of credit to our patients. I mean, we would not be here without them. I mean, oh my God, from the website design to the domain name to even now, these patients are going out there talking to their doctors. We had a patient yesterday message me. He's a young gentleman. He works at an ortho spine center in Georgia. Messaged me saying, I'm almost 90% better, struggling with long COVID symptoms. He goes, all my neurologists, I saw 5 neurologists in the Georgia area. They're blown away, but they want to send their patients to you. Great. Now that's 5 more doctors we can talk to who've got hundreds of patients that we can start helping out.
Right.
And Dr. Drew, all of us are playing a major role here, and I know
it is interesting. Those 5 neurologists. It's interesting how not so much convention, but success spreads in medicine. Very quickly, we know what works and what doesn't because people talk. They very quickly spread the word. It's quite a web. Guys, I've got to kind of wrap things up right now. I don't have time for questions from Clubhouse. I appreciate you all sitting quietly and listening to this conversation. I'm trying to think if where is Bruce leronlimab? Is it on its way? Is it going to be clinically available?
It's being used in the Philippines right now. There's a clinical trial going on in Brazil with leronlimab. Again, I think data coming out of the Philippines has shown its efficacy in acute COVID, and I think we're just continuing to see how it performs in clinical trials. But now that we've and again, when we think about CCR5 antagonism. We use Maravirac because it's available, and it is a very good drug. It's been a very good drug. It's a safe drug, so I want to curb that rumor mill right now. But the fact is, we're going to need, the whole class of CCR5 antagonists as we go forward in COVID, HIV, cancer, because like I said, it's going to be the next big immuno-oncology target.
Last question, Dr. Yogendra. Vaccines for long haulers.
So that's a tough question. What we tell patients is, again, Dr. Patterson and I are not telling people to not take the vaccine. That's absolutely, I think there's some notion out there that maybe we're anti-vax or telling. What we tell patients is,
say as clear as possible. All three of us have had the vaccine. Our families are vaccinated. We strongly recommend the vaccine. And if you have any concern, educate yourself and do informed consent, but realize you have a personal obligation beyond your own personal risk.
Except for, let's also ask for children. Somebody asked that question.
I was actively avoiding that question,
know,
but okay, here we go. So what about teenagers? You froze him on that one, Susan.
Go ahead, Ram.
Oh, good. Dr. Yogendra, I think your thing froze.
No.
His Zoom.
sorry, can you? Am I still frozen or?
We're back.
Okay. So in terms of the vaccines and the long
haulers vaccine therapies, yes or no? And what about younger people that have very little risk from COVID? Or Dr. Yogendra, you're froze again. That question seems to throw you into it. Bruce, go ahead.
Here's my point. The variants have a
hang on, Ram. Bruce is going on. Go ahead, Bruce.
I just want to make one point about the variants targeting a younger age group, and that is concerning because obviously, depending on the variant, you'll get different performance of the vaccine and/or therapeutics directed at the virus in the younger age group. But I think it's something we have to be concerned with, and we have to be concerned with the variants and those emerging.
So from the standpoint of buffering against variants, you would recommend teenagers get vaccinated.
Well, I worry that the variants will hit them, but at least that'll give them some protection.
Yeah. That's reasonable. That's the reasonable position.
We all get the flu vaccine, and it's 30% effective every year. So, something's better than nothing.
And Ram, you were going to answer the question about long haulers and improvement with vaccine.
Yeah, it's been a very mixed response. I think in very internally, sort of our sort of, if you want to say anecdotal, I was saying about 20 to 30% do get better. The rest of them, I would say, they I would say maybe about 30 to 40% get worse, and the others, it doesn't really do anything. Interestingly, in the last couple of weeks, I've been talking to a couple of these survey groups and some of the patient advocacy groups. Even those 20 to 30% of patients that do experience their symptoms getting alleviated, their long COVID symptoms from the vaccine, I would say, probably 50% of that group actually go back, after about 2-3 weeks after the vaccine, their symptoms come back again. So it's a sort of a very interesting response there. But I'll make this point, Dr. Drew, about the vaccine. If someone were to get COVID today, there's a lot of discussion. Well, there's Ivermectin and Luvox and all of these things. It's still very difficult for patients to get these medications. It's not like if you get COVID and end up in the ICU, you can tell your doctor or the hospital, give me Ivermectin.
Right.
A lot of places, the FLCCC guys, Dr. Merrick and Dr. Corey are out there getting judges to get involved in giving Ivermectin. So when you start looking at the overall picture, the vaccines can prevent people from going into the ICU, because quite frankly, if you do, it's not so simple as saying, give me Ivermectin or give me Luvox or give me one of these other experimental drugs. And any family that's been through this process knows that the EIND, the EAP programs at the FDA, it takes days and weeks. And I know Dr. Patterson's been involved in that process with so many patients. It's not as simple as saying, give me this drug, or the doctor can agree to it, but pharmacy, infectious disease, hospital administration, the FDA. So when you start looking at all of that, you know, I just think that there are, you know, there are benefits to the vaccine, even though there are some potential side effects that needs to be researched and studied. When you look at the thing, I would say get the vaccine so that you can avoid, you know, potentially ending up in the ICU and struggling to get some of these medications.
And Bruce, one more last question. That Merck antiviral that I believe is in phase 3 trial, the phase 2 looked amazing. Do you know anything about where that's going, how it's working its way through, and whether that's really going to be a game changer?
You know, what I found now being part of, you know, many different trials now is it's really hard when you get to phase 3 and the standard of care. The standard of care has changed so much since, you know, we started doing trials last March, and you know, it's almost like a moving target. And it's almost as if the bar is even higher to get approval because the standard of care has improved. And so, you know, it's really tough to predict how something will come out in phase 3 and whether or not they'll get an EUA. It's really, you know, we've seen the slam dunks, and you know, it's not so easy.
Are you getting in? You have anything in the wind about this? Is it looking good, not good, or are you going to leave it at that?
I'm going to leave it there. You know, frankly, you know, as far as treatments, if someone were to get symptoms, I would use our long hauler go-to. I would do Ivermectin.
Early, as an early treatment of COVID.
If people were symptomatic, which means the immune system's kicking in,
yeah,
I would go right to that combination.
Can you use fluvoxamine with your combo?
Yes.
Can you use steroids? Can you use steroids as well with your combo?
Low dose. Yep.
Yeah. And so you're saying prednisone, not or if it's decadron, just a milligram at most.
Yes.
Yeah.
Whatever the correlation is, but and then also Prevestatin.
Right.
You know, I mean, the virus is going to infect endothelial cells. Let's block some of the receptors.
Gentlemen, this has been great. Thank you for bringing us up to date. Obviously I could go on for another hour and a half easily. And I've seen you guys, I think on Clubhouse or somewhere, talking for 3 hours. I didn't want to put you through that.
That's fine. It's fun.
But where should we look for you guys next? We have both your Twitter handles up on the screen. It's at BruceP13 and at Dr. Yo with the word doctor spelled out. Anywhere else, Bruce, where we can find you coming up soon?
Well, yeah, I'm speaking at the Focus Clinical Immunology Conference next week, and I'm speaking at the first long hauler treatment conference at the end of the month. And then, of course, we have 2 exciting papers that'll be out there in the public domain.
Are those virtual conferences or?
Yeah, those are virtual conferences.
Can the public ring in?
I believe so, or else, you know, those talks will be available afterwards. My talk at the American Association of Immunology 2021, that was virtual. That was held back because I'm using the same talk at Focus, and they didn't want to let the cat out of the bag. So as soon as Focus is over, we'll post that presentation as well.
So will the links be at your Twitter account?
Yes.
And Rob?
Yeah, we'll release by Twitter.
Yeah, we're constantly, you know, as Bruce said, a couple of publications in the pipeline. We're constantly getting, you know, we're getting support. You know, I will say this: Steve Kirsch has been instrumental in really getting us out there, making connections, really supporting us. And I got to give a lot of credit to Steve. The FLCC doctors have also been incredibly and instrumental and supportive of the work we're doing. You know, Bruce is out there on all these conferences, really talking and really being just a huge patient advocate representing our group. And you know, we keep on making clinical inroads with getting patients better. I mean, that, like I said, that is the main goal. Getting access to the testing and getting the buy-in from the medical community. But that's our overall goal in what we're doing.
And Bruce, have you spoken to Steve Kirsch? directly?
Yeah, we just last night. Yeah,
okay,
multiple
good,
times.
because he is so frustrated with both what Ram is referencing, the medical buy-in, but also the extraordinary plotting, sort of inefficiencies of medical research. He has very little patience for that. And so I try to give him the clinical perspective, but I'm glad he's talking to you so he gets to understand everything from the research standpoint.
No, we've had great conversations with Steve. We do appreciate his insights and his help. He's like yourself, Dr. Drew. We love talking to individuals who aren't afraid to ask difficult questions. And we're not afraid to answer difficult questions. We'll never say next question. We'll answer everything that comes our way. And we appreciate individuals like you and Steve who ask the difficult questions, and because that's what the public really wants to know.
No, I know he's very worried about informed consent right now. He's worried. Generally, there's a general note for public health in this pandemic, which is they're generally treated the public as you can't handle it. And the fact is they can handle it. Those are our patients. We routinely give them all the information. That's what we do. Yeah. They can handle it. So let's get out of that mode. All right, gentlemen, I got to wrap this thing up. Thank you, those of you over in the clubhouse room. I'm going to wrap up the club room right now. Thank you so much. And you guys, I will no doubt we'll be talking again to bring things further up to date as this progresses, which I look forward to just sitting on the sideline and applauding your progress. Thank you, guys.
Well, thank you. Thank you for giving us the opportunity.
All right. And
thanks, Dr. Drew.
Susan, anything from your standpoint as we wrap this thing up?
Nope.
All right. We'll see you all on Tuesday. Is that correct? Our next
maybe Monday. I don't know.
Maybe
Tuesday
Monday.
You have that mental health guy who's been texting me.
Eric.
So excited.
Yeah. So
Eric,
we're going to talk about
I don't have
assisted outpatient treatment and anosognosia and resistance to care when you have serious mental illness and how that works. He will tell you his story about how sick he was and how he resisted care and what he feels about that.
We'll do something late on Monday night, but I don't know who yet.
Okay.
It'll be newsworthy.
Okay. We'll see you then.
Ciao.
Anyone who's watched me over the years knows that I'm obsessed with Hydrolite. In my opinion, the best oral rehydration product on the market. I literally use it every day. My family uses it. When I had COVID, I'm telling you, Hydrolite contributed to my recovery, kept me hydrated. Now, with things finally reopening back around the country, the potential exposure to the common cold is always around. And like always, Hydrolite has got your back. Hydrolite Plus Immunity, my new favorite, starts with their fast-absorbing electrolytes and adds a host of great ingredients. Plus, each single serving easy pour drink mix contains 1,000 milligrams of vitamin C, 300 milligrams of elderberry extract. Hydrolite Plus Immunity comes in convenient, easy-to-pour sticks that rapidly dissolve in water, make a great-tasting drink, has 75% less sugar than your typical sports drink, uses all-natural flavors, gluten-free, dairy-free, caffeine-free, non-GMO, and even vegan. Hydrolite Plus Immunity is also now available in ready-to-drink bottles at the Walmart next to the pharmacy, or as always, you can find it by visiting hydrolite.com/Dr. Drew. Again, that is hydralyte.com/DRDREW. Be sure to use the code Dr. Drew 25 for a special discount. I am so grateful for our friends at Blue Microphones. Not only have they completely changed what our show sounds like, they've given me headphones so I can monitor things better. This is the mic for millions of creative people, and now I know why. I'm so grateful for them completely changing the quality of our audio. You'll find Blue mics like Yeti and the Mouse, which we're using here, both in pro studios and home studios, literally all over the world. Their popular Yeti caster is a Blue Yeti microphone, plus a boom arm system that's behind many of your favorite podcasts. I run into them all the time, and now I know why. If you've ever thought about creating your own podcast or YouTube channel, Blue can make you sound and look great. Just visit bluemic.com and click Get Started, and you can start telling your story. Now, as I'm getting older, I've noticed sometimes when I feel the urge to take browns. All right, he says he has a 5-minute window before things erupt, but if he doesn't hit that window, it goes back in. Did I damage something in my youth that is causing this? Even when I have an acceptable amount of time to deuce, it all comes out in less than 90 seconds, and I'm fully evacuated. We call that talent, sir. Talent.